Hello, everyone, and welcome to the April 2021 Pre-Hospital Care Research Forum Education Research Journal Club podcast. As you all know, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Now, the PCRF also promotes research literacy and advance the science of EMS educational research. So here with the PCRF Journal Club, we take a closer look at some of the latest research happening in medical education. I'm Megan Kaori, and I'm here with Dr. Bill Toon, who will be coming in a little bit, and David Page. We are also going to be joined by some study authors that we'll introduce to you in just a few minutes. The study we're going to be reviewing today is a pilot study to assess urban fire-based paramedic accuracy in identifying the landmarks, the anatomical landmarks necessary for cricothyrotomy and needle chest decompression using live patient models. This was published in Pre-Hospital and Disaster Medicine in 2021, just recently. So we also happen to have, like I said, the study authors, and we'll have them introduce themselves soon. We're going to have Dr. David Wampler, Dr. Romeo Fairley, and Dr. Christopher Winckler here with us today to help us understand this research and their outcomes and where we go from here. But first, we have something to remind you about. We've been reminding you about this for a couple months, but we want to really push this. We still have 2 more months to talk about this, or 3 more months actually, and that's the upcoming call for abstracts. Remember, each year the call for abstracts highlights the Pre-Hospital Care Research Forum activities, and we get abstracts from all over the world actually, EMS providers, clinicians, educators, and students from all over the nation, abroad, and we use a peer-reviewed process to determine which, and blinded, to determine which authors are going to be invited to present their study. And some present at the national conference and then go on to an international conference. So remember to get your data together. Think about some of the studies that we hope today's study will actually maybe generate a little interest in doing something like this, a pilot in your own system or at your own institution. So the educational, clinical, and systems abstracts are due on June 30th, 2021. So we still have a little time to crunch those numbers and create a small, pilot study or something. And you can submit your abstract online. For more information, you can see the email that's posted on the slide. It is pcrf@mednet.ucla.edu. You can go to that pcrf@mednet.ucla.edu, and that's an email. Thank you for joining us today. We would like to begin, and again, we're going to remind the listeners that you can use the chat feature on your screen. Over to the right, you should see a chat feature. You can type in questions and comments, and we're going to bring those into the conversation as we go. All right, let's get going. So this is a great little pilot study, and we're so fortunate to have authors. We always love having authors get some really rich discussion here about research, about education, and this one surrounds the infrequently used skills. So remember, in paramedic initial and continuing education, we often teach, practice, and verify competency in what a lot of us call infrequently used skills. So 2 of those skills are needle cricothyrotomy and needle decompression. So previous research, and the authors can talk a little bit about their literature review leading up to their research question, but the previous research showed that success rates will vary widely and that there's complication rates for these techniques in both paramedics and emergency physicians. And you can go through the numbers. If you read the introduction to this article, you can get some of those references. The numbers vary, but the errors and the complications really surround placement, improper placement, or inability to cannulate when it comes to needle cricothyrotic, cannulate trachea. So, but the studies didn't really look at anatomical site accuracy. So that's the gap that they're filling. Remember, those budding researchers out there, you do a good lit review around a topic that you're interested in, and you see what's been done, and they say, I can't find anything in this other area, and I'd really be interested in filling that gap. Or maybe you run into a study that you'd like to replicate. That's another way of doing research, is maybe there's something that's done and it's only done in a system like this, and you'd like to replicate it. So that's another food for thought out there if you're thinking about doing some research. So anatomical site accuracy was the focus here, and this is a pilot study in San Antonio Fire. It's a fire-based EMS providers, basically paramedics, that were the subjects of this study. And they focused on site accuracy of experienced paramedics and paramedic educators, which is a really interesting part about this study. So without further ado, let's bring in the authors. So Dr. David Wampler, Dr. Romeo Fairley, and Dr. Christopher Winckler are all three here. And if we could start, maybe each of you can do an introduction as to who you are and what your background is in relation to the study and to each other. So David, let's begin with you.
Hi, I'm David Wampler. I'm an associate professor of emergency health sciences at UT Health Science Center in San Antonio. I'm one of the middle authors on this. Dr. Fairley is the first author, and Dr. Winkler is the lead author. And I'm just sort of in a supporting role here.
Thanks. You know what? Can you just comment on what you just said for people that are out there? What does it mean to be a middle, a first, and a lead when the lead is at the end?
So yeah, so it's sort of the bookends, right? The lead author is the one that does the most work. He's the one that he or she is the one that does the really heavy lifting. The primary or the first author does the most work. The lead author is the one that usually is the one that brings in the money, and the one that is sort of has the resources and the environment to conduct the research. In this particular case, Dr. Fairley is the one that really sort of designed the study, and it was really his brainchild that brought it about. Dr. Winkler, as the medical director or the deputy medical director for San Antonio Fire Department, is the one that has helped to create the environment to make it possible for the research to go on. And then there's everybody else in the middle. Everybody has a supporting role, and that's various workloads within that range. But it's really the first and last authors that really should get all the credit.
Okay, thanks, David. Let's bring in Dr. Fairley. Dr. Fairley, can you provide us with an introduction?
Yes, so I'm Romeo Fairley. I'm one of the assistant professors at the University of Texas Health Science Center in San Antonio in the Department of Emergency Medicine. I have a background, I did a fellowship in disaster medicine. And so through that, I'm involved in some pre-hospital research, education, and just the clinical environment. So yeah, I think I'm the first author, but definitely CJ did a lot of the work here too as well. He's the primary EMS educator for San Antonio Fire Department, and so he did a huge lift on getting this done.
Great. And Dr. Winkler, I think are you on audio or video? Oh, we do have audio and video. Great.
So yeah, thank you for the kind words. CJ Winckler, Christopher when it comes to research, but Dave Dr. Wampler may be a middle author on this paper, but he's always first in my heart. We work at the Office of the Medical Director, and he really helps guide all our research here. Dr. Fairley and I have a good working relationship through Department of Emergency Medicine. We're ER doctors. I do make my full-time living, however, as an EMS physician, and I was a paramedic before for 10 years before I went to medical school. So yeah, as the lead author or sometimes the senior author, I'm heading towards senior every day, I think. But as the lead author, you really kind of are in a position to help facilitate the research. And Dr. Fairley, and I should say Dr. Tanaka presented this a while ago, and I was like, this is a great education project. As was mentioned, I'm also in charge of the medical incumbent training program for all our paramedics at San Antonio Fire Department, which are about 700 paramedics. I think I'll leave it at that.
Great. Thank you. So Dr. Fairley, let me bring you into this, and because you are the person who came up with the design for the study, probably with your team, but take us through what brought you to this particular topic and your study design and led you to say, let's do a pilot program on this.
Sure. So I think, and I agree with Dr. Winkler, some of the credit share should go to Dr. Tanaka, who's not with us right now. She's actually moved to Buffalo, but This study was a part of a grant, a series of studies in combination with the military here in San Antonio, looking at pre-hospital airways. So we actually did a series of studies on successful use of different cric techniques, of different models, what the current literature base is, and then this kind of spun off of all of that data, saying, well, what happens in our civilian paramedic world? And so we realized that there really wasn't very much evidence out there about what the paramedics are looking at and what their accuracy rates are, just purely at the anatomical identification. And does that promote a placement of a spot for education? And so that's where we started.
So was that then, you mentioned you did previous studies. Did you compare devices then in the past?
Yeah, we we actually had we have a concurrent project right now on the military side where they looked at comparing the iGel versus just any other supracholic device versus a cric versus an intubation, and looking at the different techniques to see what are the success rates among those on pre-hospital providers.
When it came to needle decompression and needle cricothyrotomy, had you done comparison of devices there? That will be a question actually coming up, is which device did you use and that kind of thing in this. And actually, this was an anatomical accuracy, so I assume that it wasn't a device study, but had you done that in the past?
We did not look at the different, for example, like the cric key and things like that. We didn't look at those specific devices. And this specific study, we only looked at, can you put your finger on the mark? We didn't look at the actual devices for this study. But that is one that's planned for on the military side. That's
great, because when you did your literature review, I'm really curious what led you to this specific subject, the anatomical subject. I think there's kind of an assumption that when you talk about some of the research in your introduction and your background, that the complication rate, the error rate, did surround inappropriate cannulation of or missed cannulation of the trachea and needle cric, and not being accurate at the sites for pleural decompression. And I'm not sure whether there was a common feature in any of those studies. Was it too high or too low on the chest? Was it what were the features of it? Was it getting the inferior border, or what instead of the superior border? Which were the errors? But how did you come to landing on, because so many people focus on the clinical treatment, right, as the possible cause? Well, these devices don't work and we should be using a different device. But you decided to go to anatomy. Why specifically anatomy?
Yeah, I think that's a good question. So in my mind, when you break down a procedure, it starts with, where does the procedure even go? What landmark do you use? And if you can't get that spot right, then you're going to fail. Like, there's just no way. So when we looked at the literature, and Dr. Schauer, who's actually one of the authors on this paper as well, is the lead for the military grant that kind of funded all of this stuff. He did a series of papers on what were the complications and what were the causes of those complications. And a lot of them were that we could identify, at least. It's really hard to say retrospectively, but that they just were in the wrong spot. They were too high, too low, they just couldn't see due to the anatomy. And a lot of that was based on the military environment. So some of that's much more difficult due to just the trauma that their patients have experienced. So we wanted to start with the basics, and we didn't see any literature on that. So we wanted to see, are people able to accurately pinpoint the location?
Really beautiful. I mean, I think that's, I hope that we have a few listeners out there who are thinking about doing research, that, oftentimes our students and other paramedics and working paramedics are a little afraid of research. They think of it as, p-values and tables of numbers, and that it's so far out there. and doesn't really matter as much to the direct, boots on the ground kind of EMS. And this is a good example of something that's very simple, very intricate, and very specific, and targets something that has not been done well. So I think that's great. When you went to then the next step, and so we want to do this anatomy study, did you have any discussions with your study team about mannequins and people and cadavers and how to get at this?
There was a very brief discussion, admittedly, but the same way we did it on the military side, I'm looking at this, is we tried to get a little bit of more of a real world experience. So on the military side, they ended up using the full cadaver and then some mannequin heads. On our civilian side, we really wanted to see, okay, how does that translate? Does that differ between actual people? And granted, that introduces a lot of confounding variables and a whole lot of stuff that you just can't control for when you take real human as your anatomic patient. But it makes for a more realistic scenario, and that's what we were really going for.
Great. Yeah, and I guess if you have you talked about body habitus, the different body sizes and anatomies and hair, tattoos, other things that might be a distractor for someone who's even though you're feeling for the location. Now let's get into, and you can, and feel free, David and CJ, to jump in at any point too. I was focusing on Dr. Fairley because you were sort of the primary person who designed this. If you can now take us to how you went to your subjects, tell us about the study and who the subjects are, and I'll just advance to the first table here.
That actually may be a good one for Dr. Winkler if you're up for it.
Yeah, so we have, this is a career at San Antonio Fire Department. I think you can see when we have nearly 60-year-old paramedics out there working that this is a career. So we have as most systems do, we call them MTOs, medical training officers. Many systems call them FTOs, field training officers. But we have a rather diverse age group, 27 to 58, of folks that are medical training officers, and that's just what it sounds like. These are folks that train the next generation of paramedics to ply their craft in the pre-hospital setting. So we have experience from 6 years. Generally, at our system, the reason that minimum years of medic experience is 6 is we kind of have a build up at this system. First you're a firefighter, then you apply to get into EMS. So you it's a nice building block here once you're hired on in San Antonio. And then we have a 38 years of paramedic experience, with our average being 14. That's a nice seasoned workforce that does play into one of our kind of primary questions for this study. And then so someone that had never done a surgical airway and someone said they had done 50. I don't know where that is, and we didn't have the fidelity to ask. We do have a lot of military folks in our service, but I don't know, exactly who did 50, and we don't know because that is. Yeah. But the average kind of makes sense to me. The surgical airways, the average is 3. That probably the median would be less than 3, just if I had to take a guess. And then chest neural decompressions performed, and these are actual patients, not in our cadaver lab. So this is actual field performance, but the average is 10. And we do encourage, before we pronounce any one system, just as a matter of clinical practice, to pronounce a traumatic circulatory arrest patient, that we do bilateral pleural decompression before we pronounce. I think I covered this pretty well. If I left anything out, Dr. Winkler or Dr. Fairley, please step in and fill the gaps.
Yeah, I think I was surprised at the number 50. And I think in your paper there was something that said that, and I thought it was in this table, maybe it's a different one, that it was a combination of simulated and live patients. So I'm not sure, are these all live?
Maybe I might have to I might have to have Dr. Fairley step in and confirm that. So
the original question asked for if it was cadaver or real life patients. However, we don't know each individual person if that 50 actually is real patients or a combination of.
That's
specifically asked them.
Yeah, that's quite possible. You have a cadaver lab, and so if they, you're required to do X number every year, 5, and if they chose to do more that year, that's perfectly plausible that they did do 50. But interestingly, that number is not written down in our cadaver lab training, so they'll just have to go off of memory.
Just out of curiosity, do you have cadaver lab training for all of your paramedics?
And EMTs, yes.
That's wonderful.
Yeah, it's pretty fantastic. We spend, so all paramedics every year spend 8 hours at the cadaver lab, and then EMTs every other year will spend that time.
And how is that organized? Is it, and how's it been going since COVID?
Yeah, great question. So we continued the cadaver lab through COVID. We N95s and changing gowns, etc. It's going great. It's a fantastic relationship we have with. I just have to say Scotty Bolliger in every podcast I seem to do, but Scotty Bolliger, who helped invent the EasyIO, has a cadaver lab at Everitt Spring Branch that we take full advantage of. We're very proud of that. We're proud of that relationship, proud of that program. So thanks for correcting me. Yes, we did include those. I'm looking at the study. We did include cadaver labs, and that's thank you for that. But it is a fantastic relationship. We think it's valuable and useful.
Great, David. Did you have a comment?
Well, so I just have, as the data geek guy, I just have to say, so the number 50 seems a little out there, and clearly by looking at the numbers, it is truly out there. Because if the average number of surgical airways is 3, right, and our maximum is 50, that 50 is really powerful when it comes to doing averages. And so clearly those numbers are outliers. So this is probably a person that teaches in our cadaver lab, and he does these every week. So that's that's probably where that number has come from, because this is a person that is very experienced at not only doing them, but also teaching them.
Yeah, this is great. So this gives us the baseline information about the people who are going to be performing. That helps us as readers. And again, for those of you out there who, if you haven't read this, please do take a read through. But this demographic table helps us, decide what other factors might affect the ability or the accuracy when they do launch this study. So they measure these and look at these things that might affect the ability of the paramedics to identify the site to begin with. But this is a nice wide range. You actually do have a cadaver lab that's regular, so that makes a difference. So you would think that makes a difference. I have a quick question about, Dave Page, you're on here somewhere. Do you remember when we did on this podcast, we talked about a study and it was the one that combined, it compared procedural skills training and it's focused on the cognitive part of it, the why, right? The learning of the anatomy, the learning of the why. And they compared interleaving that cognitive information while you're learning the procedure versus what we usually do, which is have a lecture, then have the procedural training. And the outcomes of it was retention, and the retention was much better in the group where you interleaved it with the procedural training. Do you remember that?
Absolutely. And I think it bears mention here that I too have visited Spring Branch and been there with Scotty Bolliger, and that interleaving in this lab is very much a part of it. So the person facilitating a lab, I think, plays a key role, and our listeners need to know that there is a whole lot of when would you do this? Why would you do this? Okay, now you have this going on, and not just the concept of, well, here's a mannequin, you know, here's where you put the needle in. So much of what we do, even around the world, we have guests here from Ecuador, Chile, the Philippines, I think Germany. So much of what we do with the PHDLS courses, et cetera, is teach people how to identify the spot and where to put the needle in. But it bears mention that this cadaver experience is much more of a simulation environment, and that the immersion there is quite intense. So these are experts at weaving why as well as how, and I'm glad you mentioned that.
Yeah, I mean, you think about the difference when someone is, you know, feeling for the intercostal spaces, and the student has a question, says, okay, but what happens if I do this? I mean, have you ever done this, and what has happened, you know, in the past? And so it makes the educator have to be, you know, that much more ahead of themselves, that more familiar with the literature, or at least familiar with seeking the literature to find out if that, you know, and the cases, the experience of maybe your local trauma center or something like that, where they can answer those questions. So yeah, that I just thought of it when they were mentioning.
And there's also risk benefit, right?
Yeah.
So I think that here the authors can comment about this, but I think the risk benefit of some of these procedures, they're rare procedures, but when done in a certain moment could be really the difference between life and death. And so when done improperly, there's also a risk. And in a cadaver lab where some of that can be explored, you can actually show what happens when you don't really actually, you know, hit the right spot is really important. I also think it's really impressive that, you know, for people with 40-year-olds that actually have 14 years of experience can be engaged in this kind of learning. And it's just a mark of a good system that can do that kind of education and still have people engaged, because, you know, some of this has become so automatic. It's just kind of show me. The mannequin already has, do you know this part where it's got all the little dots where you already inserted the needle about 50 times. And so it's like you're not even guessing anymore. You're just going, okay, do you want me to take this little thing and put it in here? Okay, am I done with the station? Can I move on to the next thing? And it really just is not good education. So I hope everybody realizes the background to this, and the study population is abnormal, and the location is, you know, sort of a 5-star location. So I'm glad that we have that established. But I know Dr. Wampler is going to say something.
Well, no, I just wanted to feed off of that conversation, because, you know, these are low frequency, but these are one of the few things that we as paramedics and EMTs that can do that actually saves lives that other people can't do, right? Because, I mean, Dr. Winkler and I have talked extensively about this at many conferences. What is it that we as paramedics can do that save lives? Well, we can defibrillate, but so can my 14-year-old son. We can give epinephrine to somebody who's asthmatic. That clearly saves lives, but so can my 15-year-old son. You know, we can do all of these things, but they're really layperson. So these are the two topics that, you know, really takes a paramedic brain and an EMT brain to be able to do. Identifying the landmarks and getting the actual procedures, and knowing when and where and why and how to do it is also the important pieces. So I just wanted to sort of feed off of that a little bit and really bring about the fact that this is one of the things that we can do that we are pretty sure is going to be able to save a life. And it's one of the few things that we can do that nobody else can.
Yeah, and I think you made a point in there too about that it's not just about doing. So one of the things I teach initial paramedic education, and one of the things I think every paramedic student is surprised about is that paramedic school is really not about advanced procedures. It's more about 90% of it's about advanced assessment and differentials. It's knowing when, why. It's really knowing that kind of depth. So I think it's really important that is interspersed in here. CJ?
Yeah, just to tag on, Dr. Wampler and I have, it's one of my favorite talks I've ever done when we just talked about, I got BS in a title at EMS World, but we said BLS is BS in the spirit of that was BLS is truly the life-saving stuff. Like basic life support has transitioned to, as Dave said, Narcan, et cetera, et cetera. And just to really tag on to what y'all said, the advanced stuff, the low occurrence, high acuity stuff really is when to do it. But also, this study was just so succinct about, do you know how to? And you know, I'm proud that we had all the capability to do that, et cetera. I just wanted to tag in and say that you know, if I don't know, maybe our listeners can think of things that the paramedic does that truly saves a life that the EMT does not. Favorite topic, to chime in.
Great. Okay, so now we know who we're studying. Let's talk about your methods a bit, and then what you found out, and we'll bring up the study results. So who were these folks? We mentioned medical training officers and experienced paramedics. And how many did we have, and who wants to take that on? Dr. Fairley.
Sure. So I think on the next slide, I think we had 69 participants. One of them we actually didn't get a full data set on, and so we excluded them from the actual study, but we had them participate. And so the process was we over multiple days, the paramedics get a series of education. And so we went in on these days, requested it for any volunteers, and asked them to consent and kind of explained everything. Once they were okay with that part, we split them up into groups of 2. And each team of 2 we would take into a separate private room and then go through the procedure with them. So the procedure was we would randomly select one of them to go first. That person would take off their shirt. The other paramedic in the room would identify using a marker. We use just a tongue depressor, a marker to mark their cricothyroid membrane, and then mark where they would do the chest needle decompression in the second midline intercostal space, as well as the anterior axillary fourth intercostal space. And so we timed that as well. And once they completed their mark, we would verify the position right or wrong and go to the next person. And then at the end of that, we gave some brief education to them saying, you were wrong because of XYZ, here's the actual placement on this person. And that way everybody got some benefit out of it.
Okay, so we're looking at right now the tables, correct? The 2 tables of the results. And in your hypothesis, you had hypothesized that the medical training officers, the educators, would do better than the experienced paramedics. So what are we looking at here? If you can walk us through the 2 different tables here.
Sure. Yeah, and that was definitely our primary hypothesis. We assumed that the medic training officers would be faster and more accurate. But so here in table 2 and 3, we go through the time on table 2 for each site, and then the accuracy for the combined ones, combined MTOs and field paramedics in table 2. And then in table 3, we have just for the MTOs. So if you look at them, essentially there's no difference between any of the groups. So just the MTOs, the training officers, and the field paramedics were all equally fast and all had a pretty much equivalent accuracy.
And it was from the time they touched the patient till the time they identified the landmark, right?
Correct. Yep. We said, okay, stand, next to the patient. As soon as you put your hand on the patient, that's when the time starts. And then when they essentially said, okay, I'm good, that's when we would stop their time.
Okay, and I'm sorry, we've got tables 2 and 3 on the same, but 4 is on the next slide. So the first one is the combined group, and then the second table here, table 3, is the time to identify and the accuracy, and this is just by the medical training officers. So table 4 is going to be by the experienced paramedics, and this is so the one thing that stands out here in the first table is the 63.2%. I think this is what Dave was talking about earlier about the difference in the site accuracy between the second intercostal space and the fourth intercostal space in axillary. You know, the midclavicular second intercostal space versus the axillary fourth intercostal space in both, you know, overall and in the medical training officers. And then, and I'll advance this, but go ahead, Dave.
Well, I would love to hear more from Dr. Fairley here about, you know, whether or not these were surprises, because they are. It's funny to me when we think it just takes 2 seconds to do things. How hard could it be that, you know, you put your finger there, you find the clavicle, you slip your finger down to get. It should be pretty quick. But if you don't do it very often and you've forgotten exactly where things are and you're afraid of doing the procedure, I thought that's impressive that, you know, on average, it takes about 10 seconds to really actually find these things. And then the accuracy thing blows me away. I just think maybe we're assuming that people put needles in the right place, and that's not necessarily a good assumption. These are experts in a very controlled environment that were actually quite experienced.
Yeah, I think those are very good points. The timing did surprise me, and we actually have had comments from people who've read the study of like, why did it take people so long? And you know, I think it's one of those things that if you ask somebody, oh, how fast can you do a procedure? How fast can you intubate somebody? How fast can you put in a central line? They'll say, oh, you know, I'll do it in a few minutes. In reality, if you actually time them, it takes a lot longer than people anticipate.
Yeah.
And the other part is, you know, these people knew that they were being recorded on their accuracy. So many of them would put their finger on the mark and then kind of look at it and play around and make sure and spend an extra few seconds verifying that their position was correct before they would say, okay, I'm satisfied. So that may have played a role in this as well, versus, you know, in a real life scenario, maybe they just say, okay, I got to get this needle in, and they do it. It's hard to differentiate that.
So I have a question about the primary outcome and how you selected what we called accuracy. So when we're measuring something, the accuracy of fill in the blank, we need a gold standard to compare it to. So it's not an X-ray, it's not an image, it's not whatever. It's another expert. So in other words, in order to determine if the paramedics or MTOs were accurate, it was an emergency physician. That's correct, right? And then there was a second opinion, and then there was a third if and it was videotaped. So the second opinion about the whether or not it was accurate came through a videotape analysis, and then if it needed a third opinion because of the disagreement, then a third physician came in. So that was what was outlined in the study, I believe, and you can correct me if I said that wrong. But my main question comes from the literature review that lumps in emergency physician inaccuracy as well. So what made you choose emergency physician as the goal? I mean, no cut to emergency physicians, but in the background, you're saying, well, you know, EMS and emergency physicians are, you know, the accuracy varies widely. So we used emergency physicians as the gold standard to tell us whether they were accurate or not. It seems a little counterintuitive.
That's a fair question. So the literature review showed the failure rate of the procedure, and so, you know, ideally the failure rate is based on not the location selection. But that is why we had 2 emergency physicians in the room at all times trying to verify these placements. And you know, we didn't say this in the article, but the time that we needed a third person was on the fourth intercostal space. And the question becomes, is it the fourth intercostal space or is it the fifth intercostal space? And sometimes that can be hard to really get up in somebody's armpit and depending on their body habitus and count that first rib. But outside of that, you know, for us, we felt pretty comfortable with our anatomy verifying those locations. And it was always a handful of 3 or 4 of us emergency physicians that we trusted that had done enough of the procedures and done enough of the anatomy review. But that's a fair question. It's definitely a limitation on the study.
I don't know how else you would do it, you know, if there's sonography or some kind of other imaging way that might be, I really don't know how else you would do it. So, but it just came to mind because of the background. We do have some questions and comments coming in that we want to pull in. And one of them I'd like to pull David, who has said he's the self-proclaimed numbers guy. You got to bring the numbers guy back. We do have a question about the use of the from Nick. Thanks, Nick, for sending this question, and be curious to hear why, if there is at least some outlier data known in the data set, means were reported instead of medians. So I don't know, Dr. Wampler, if you want to comment on that at all. Did we lose David? Well, any of the others who are still along. Oh, there he is.
Oh, nope, I was talking. I just made a rookie move and forgot to unmute myself.
Okay.
That's a valid point. We chose to go with the mean because really, I think the mean is pretty representative of this group. We have some outliers, but other than the outliers, the data is pretty normally distributed.
Okay, great. So that's we always get sort of numbers kind of questions in here. We also had a couple of comments, and I just want to thank you for putting in your comments in the chat. Lance was going back to the cadaver, saying 37 continuing education courses each year, 40-hour class with 1 full day of non-embalmed cadaver training. I think there's a lot of us educators out there who would love to know how to you know, gain those relationships and obtain that kind of regular training, either in initial or continue or both. Really, continuing education for paramedics. Probably continuing education is most effective. And then we also had a comment and a story from Christopher that he had an incident for needle decompression with a 30-year-old female, vehicle versus motorcycle, massive chest trauma, ribs, sternum, clavicles all broken and displaced, landmarks essentially impossible, and it caused what he puts in quotes a protocol violation. If he was unable to identify landmarks, the procedure is contraindicated, and the same for Cric, and said, I did it anyway. So there is some of that, you know, and this is again what we get to in paramedic school, that this is more about, this is about clinical reasoning and paramedic judgment and critical decision making. More, you know, it's hard training initial paramedics. You want to give them a skeletal structure of those check sheets, but you know that there's, you know, you got to pull in the whys and the situations and the cases, and it's your decision on the moment as well.
Yeah, and we're going to discuss this in the limitations section. It goes back to patient selection, right? This is a real world study. We're using real humans with real anatomy. Our particular project looks at pretty healthy individuals where anatomy is as expected. Yeah, once you get the trauma patient, the anatomy gets distorted, or you get somebody who has, you know, significant obesity or other anatomic anomalies, that complicates the issue and it makes it more difficult to identify the process. So that's a great point.
Yeah. So what was the reaction of the paramedics and the field providers? I'm sorry, the field providers and the educators when the results came out? And any of you can comment on that who work directly with them. CJ or David, I think you guys work directly with the medical educators.
And while they're noodling on this concept, I'm also curious about this 50% accuracy. You know, how off were they if you were in the room, and if not, if they were really far off, how do you feel about the fourth intercostal space being the actual recommended first line decompression site? And you know, that concerns me if I may be so bold.
Yeah, so great question, and it segues in to what I've been dying to say this whole time, and that's it tags on to what we've talked about earlier about it would be great if other folks did research and picked up some of the gaps that we have in this research project. So one of the gaps we have in this research project is that as a matter of clinical practice at San Antonio Fire Department, the medics are allowed to go in the 4th or 5th intercostal space on the axillary line, mid-axillary line. So we did not, the study was not designed to answer the question of how did they miss, which is what I would love to know myself. I would say just from being there for all of them, there were a few misses high on the cric, so above the glottis, which is a concern. There were more misses low, which is kind of to be expected in my mind. And then on the needle decompression of the chest, I personally was a little surprised that the mid-clavicular was more accurate than the axillary. That's just my personal bias. I would say that. So as far as the MTOs, especially missing at a rate of half, I would say that my hunch is, and I don't have any data to back this up other than being there, is that they were most of them were in the 5th. Some were posterior and some were anterior. And I would love it if we had another table for you, Dave, to answer that question, but we don't. We did not design it that way. But that the next person, please bring that on because I want to know too.
Well, those who can't teach, so maybe the training officers are actually in a podcast for educators. I'm sure I'm going to get murdered there, but I think. But this is why context matters so much, right? Because if you jump from a perfectly good airplane without a parachute, you could survive because the airplane is on the ground, right? So Remley Crowe loves to tell that story in that research project because, in fact, you could have a concept that we've been overtraining on second intercostal space. And so we emphasize that for the last, I don't know, at least the last decade in my brain. When I started PHTLS, 1987, and so we were really all about the McSwain dart back then, and were we going to stick, a big old thing into the side of the chest. And then now are talking about, doing finger thoracostomies and using a scalpel. So I think we where we put that needle and how we train people and how they tend to think, well, if the educator said I could have some slop southward and hit the 5th intercostal, then 4th or 5th, who cares? And maybe that's why we've got a 50%. 52% accuracy there in identification of the 4th intercostal versus the we drilled, where's the midclavicular line? Fascinating. And I do think this is why we need research. This is why. And this is so fascinating. We can do this with our students as well as our continuing education classes. If we think ahead and just do a little bit of pre-planning to just figure out, do people really actually know where the thing is? It's always fascinating that the science that came out on the how effective chest decompression was in particular also had to do with the needle length. And so this context of does it actually work is in practice not just related to whether or not we get deep enough or we identify whether it's actually happening or not. Could it be that we misdiagnosed the tension pneumo and there was no tension pneumo, but also where are we putting the needle? I'm also curious about just from the author's perspectives. Now that cricothyrotomy is not recommended in the latest PHTLS, that this cricothyroid membrane identification maybe a discussion about just whether or not we can accurately perform a surgical airway. And if we can't identify the landmarks to put the needle in, are we going to hand people scalpels? So was this leading up to, because you in the title call this a pilot study, which is great. Does this give you a thirst for a broader paper, a bigger project? And are you in the trauma system able to identify those patients who still might be getting some of those procedures and then in a post-mortem figure that out? Is that kind of your next steps from here? Uh-oh, there we go. Okay, there's Dr. Fairley.
That's a good question. So the pilot for this came from, as I was mentioning earlier, from some military grant funding is where this spun off from. And so the TCCC guidelines, they go essentially from, very basic airway interventions to cric. And so jumping from there to there, on the military side of this, they're trying to see for these pre-hospital providers, what's the actual ideal airway intervention? And so that's kind of where we started. I think going forward, as Dr. Winkler mentioned, we really need to see why are these people missing these landmarks, whether that's for the cric site or for the needle decompression sites. Why are they missing, and how can we improve that? And so I think, especially with us being educators and talking about education, is how do we improve that? How do we improve the cadaver lab? How do we improve our mannequins, our models, our processes? Is there something that we can do to make this 100%? Why can't people just, put their finger on it? Which is obviously a difficult question to answer, but that's the goal.
Yeah, that's great. The other thing that you mentioned in your, and by the way, the limitations section in this I thought was really solid. And if, again, the researchers out there, check out the limitations section, which goes through, as you're reading an article, you might come up with, well, what about this? Well, what about that? That might limit the research. And that should be covered by, researchers in the limitation section, that it was a convenience sample of, 69 majority male participants from a single service, that we can take this, so far. But I do want to say that, Dave, you and I have talked about this a lot in this podcast as well, that don't throw the baby out with the bathwater when you're looking at limitations of research, and also when you're looking at intricate studies like this that pick one piece. We know that medical education research should translate out into outcomes at some point, but that translation is a huge leap. It goes through several levels. Are you accurate in your identification? Can you perform the skill? Then does it make a difference in clinical practice? Is another translational level. Then that change in clinical practice, does it make a difference in patient outcome? So there's multiple steps in there that have to be happening, not just one giant leap. So those of you out there who might be saying, well, who cares, because we don't even know if this makes a difference in outcome. It's a very important thing to have these intricate, either observational or interventional studies like this. This is a great example of a piece of educational research. It's incredibly possible for you educators out there to do, whether you're doing continuing or primary education.
And I think the authors themselves point out here, the study population may have underrepresented potential extremely obese patients. Mm-hmm. And so, you've got both issues with landmarks in the neck and chest that are really very different when we're talking about, accuracy, as well as this concept of, we've talked a little bit about cognitive load in this podcast, and in simulation as well as in real life, the concept, you're not doing this when you're kind of in a well-lit room with people just sitting around talking. You're under extreme conditions in a usually less than ideal noise environment and or light environment, and you're relying on touch a lot of times, which is gloved, and now even more with fogged eye protection. It's sort of like the blind leading the blind, going, okay, is this the right time to do this? Is this the right patient? You know, is the decision to do this the right one? So, you know, I couldn't agree more. Yes, it's a limitation. Maybe the results aren't generalizable because it being a small sample, but in fact, I think it's a large sample, 69 people in a study. And yeah, it's not everyone, but it's a large group of people who are in a very focused environment. They're professionals. They're very well trained and experienced at this. So what does that say about the you know, so super rural, super infrequent, perhaps less than ideal training? You know, I'm guilty of taking a rack of ribs and putting some plastic around it and going, okay, here you go, feel around, that's where you put the needle. You know, before I started thinking, well, what if I just tape that to the person who's pretending to be my patients to their chest? And we don't, you know, I think as educators, we better be thinking, let's find a way to, you know, get that rack of ribs stuck onto our victim, and let's create some, you know, extra padding on there so that it's less simple and people have a little more confidence and a little more accuracy. So yeah, I also love Lance's, Dr. Villers is on the chat here as well about previous studies with first responders and not being able to, you know, 45% couldn't identify the fact that there was a pulse present under a certain blood pressure of 80. And I think the entire concept that we do things by feel is a concern, and I would be curious about what the authors think about using here ultrasound, because that has actually begun to look like it's a little more accessible. In Japan, I saw a probe that was, you know, hooked up to your phone, so it may be a lot more accurate. And could it be that the future looks very different as far as where we stick needles and even identifying whether or not there is a tension pneumo versus not? So do you feel like ultrasound is going to help kind of change this question and help us with this landmark identification, or do you think it's just high tech, you know, not even worth it? Dr. Winkler, Dr. Fairley?
Ultrasounds do cost money, and they do require a lot of training. But to answer the question wholeheartedly, I do think that ultrasound is going to be part of our arsenal in the future, our being EMS writ large. We are working. I'm a firm believer in the Chris Evans paper about reanimating traumatic circulatory rest, and part of that is the patient dead or not? And just to be frank, and ultrasound can help you with that. And so on my to-do list, Dave.
It's a short to-do list, I'm sure.
Well, it is a sentence in the paper. A device to assist anatomical location identification could be beneficial. So I'm going to assume a device is ultrasound.
We put that in there very vaguely. Part of the military grant was actually looking at potential devices for creation. So not necessarily an ultrasound, but an ultrasound is definitely on that list of tools. I'm a believer in ultrasound, but I always like to put a caveat in there. There's time and place for everything, and just because we can, should we? So, you know, should we be looking at trauma patients with an ultrasound in the field instead of just getting them to the trauma center? And questions like that are definitely a much larger research project.
Do we have any final comments? We're up at the top of the hour now, ending this. It always flies by. Any final comments from our panelists? Thank you very much for David Wampler and CJ. Come on in.
I can't show my camera because I was told I'm not allowed to have my muscle shirt on.
And Johnny
Since,
come lately from Arizona, the
well,
retiree.
yeah, but I was the
River.
gym. I was the gym. I was doing something healthy. So,
Yeah.
Dave, don't even, I notice you cover your muscles all the time. So, first, there was a comment made in there about continuing education, and having worked
Yes.
for 20 years of my career as a full-time continuing medical educator, which I thought was a well-funded department. It is still even a well-funded department. Continuing medical education is just a small percentage, and the budget often gets cut very quickly in that area. That makes it difficult to do some of the type of training you would like to do, or to the level that you would like to do. And I think it's, in a lot of cases, there's plenty of people that says, boy, I really want to do this, but it costs money. And that's a setback for people. But I want to thank you. This was a well done paper, and I want to thank you for sharing it with us. It was really a nice step in the right direction. And as you said, we need more work like this in this area to help us really get to some of those answers, and to get, as Megan says, to the final thing. How does it impact the patient? You know, and that's really where we need to get. But I want to thank you so much. It was a great paper, great discussion.
Thank you.
Thank you.
Any final thoughts for us, for our educators out there?
I think, yeah, I think you've covered it all. You know, even if you just build on this research paper, that's a good start, right? Like, I mean, this paper, I know the gap, we all know the gaps, we just were pretty honest about them. So any paper you find like that, fill in the gap. And it really, the first step is the hardest. And once you get over the initial decision to do it, then things will fall in place.
Right. We also want to point out to our listeners that you can always find contact information in a research paper on the front page, where you have the references as to what are the you know, the associated institutions. There's a correspondence area, and so you can get Dr. Fairley's contact information if you have any questions, further questions about the research, or any questions about maybe furthering this research in your own area. So we'd like to thank you all for joining us, Dr. Fairley, Dr. Wampler, Dr. Winkler, and especially you educators out there. Remember, we are back in May, 4th Fridays, 10 a.m. Pacific, noon Central. That'll be May 28th. But we're back earlier than that with the next PCRF clinical podcast, and that'll be on Monday, May 10th, 10 a.m. Pacific, noon Central, as usual. Thank you to FISDAP for sponsoring, and the Prehospital Care Research Forum on behalf of PCRF. We're signing off. See you in May. Bye-bye.